Yeah, it definitely is interesting. And you said that I would be expert on pain. That's definitely not true. Maybe it's like being over 40 and training every day. So you you, you are like every day scanning like, oh, there's a little pain in the foot. Is it an injury or is it normal? I need to walk a little bit, like see what's the pain coming from. And should I be worried or should I just ignore it? So maybe it's from there. And for the listeners, I have maybe there's an episode, maybe I remember the name wrong, Joshua Pate. There's, for example, he made a book about pain for children, and we discuss, I think we have 3 episodes with him discussing about pain. So if you're interested on topic, you can check that one. And yeah, so it seems that physical activity after surgery and pain, they are not linked. Yeah, so you have done also study on impact of pain on daily activities. Could you tell more about this study or studies and tell about the main findings?
I'm moving a little bit from the acute post-surgical pain here to chronic pain.
Yeah.
As I said earlier, chronic pain is a little more complicated because the reasons are not as clear as if you're in the hospital and have an operation. Although sometimes chronic pain is also the result of the operation, then it's called chronic post-surgical pain, but that's just a side note. And there has been a lot of research on that, or at least more than in the acute phase. And researchers have found out is that the patients need some time to get back to normal activity levels. After surgery, for example, 1 week is not enough. We also found that in the previous study. Patients get back to normal activities after 2 or 3 weeks. Some never go back to their previous activity levels. What we do know is that patients with chronic pain move less than their healthy counterparts. So if you look at patients that are a healthy population that is equal in demographics to chronic population, they are moving less. In chronic pain populations, you have different types of people. Some are pacing through their pain. Yeah, they would do what you just said with your foot, just walk over it. Some are laying back. Some are having much more sedentary behavior, watching TV, not getting up. And obviously, this is not big news. This is not very good. This is not good for recovery. This is not good for your overall well-being. It can increase heart problems. It makes you gain weight if you don't move enough. And it's a vicious circle, yeah. If you don't move enough, you have problems, your back pains get stronger. And if you have back pains, then you don't move enough because you think it might your back pain. And then this vicious circle goes on. And we really see that in chronic pain patients that come to our hospital to get treatment. They need to be activated. They need physiotherapy. They need professionals to show them sometimes how to move. They have movements that prevent their pain. I don't know if this is really the right word, but they try not to move in certain directions so that pain is not evoked. But this leads to wrong constellations of the body. Yeah. So they are not lying as they should lie. They lie somehow differently or a little trumped or something like that. And about this is bad. And learning to get back to normal daily activities is very important to at least reduce pain if it cannot be removed at all.
And you've been also studying the post-operative nausea. Could you tell a little bit more about this study?
Yeah, nausea is a result of some surgical interventions. When you go to the hospital, you get anesthetized. Some people get nausea afterwards, and this also could hamper the recovery process. It's obviously an unwanted result. And the funny thing about it is that the ratio of patients that have nausea is not really improving a lot. Yeah. So we found in several 100,000 cases in Germany that the nausea incidence is still 20%, which is too high. Nobody in the hospital wants that. And that is even though we now have nausea prevention schemes in the hospitals everywhere. There are drugs out there that can prevent nausea or at least reduce it. But nevertheless, we still have 20% of patients that answer to our questions, did you have nausea with yes? And that is a lot. And what we wanted to do is we wanted to find one specific risk factor for nausea. There are others out there that are known. There is a so-called Apfel score. Yeah. So, every clinician knows this score. There you combine some factors like, for example, if you're a smoker, if you're female, if you have a history of nausea, and if opioids will be used during the operation. If you have a higher score, you have a higher risk of nausea, and then you should get nausea prevention. But what is missing is the influence of the surgery itself. So there are different kinds of surgeries, and this impacts the nausea was not really known beforehand. We actually, one of our co-authors, Peter, was a co-author also of UPFIS and was at the time that the UPFIS score was released in this field. And he said that at that time they didn't have enough data to look at surgery. And our idea was to look which surgeries are most risky for developing post-operative nausea. And so we took a large data set and analyzed it in a statistical model and adjusted it for age and sex and opiate consumption. This is the stuff we always do. Yeah, we always use age and sex. I didn't tell you before, but maybe it's interesting. Younger patients develop more pain and also more nausea, and women also report more pain scores. So the normal adjusting factors that we always use. And in this case, in the nausea study, we again used these adjusting factors and then looked at which surgeries were most prone to develop nausea after the surgery. And we found out that there is actually a large variability. As I said, 20% on average, but there are surgeries like cesarean section where it's just 6 or 7% of patients, or in this case, mothers developing nausea, but others, for example, bariatric surgery or prostatectomy, they have like 30 or even more, 35, 36% of them have nausea, which is obviously a pretty large group. And the conclusion of this study is that the score is fine as it is, and it is a very good tool. But clinicians still need to be very cautious about their patients, and they should treat their patients according also to their surgery. So for these high-risk surgeries that we found, they should be open to looking again at the patients afterwards. They should use more nausea prevention drugs. They are called antiemetic drugs. So in principle, if you have a bariatric surgery, every patient should get this before the surgery so that they don't develop nausea. It could probably not be prevented totally for everyone, but it could be reduced. And we also looked at how many patients got this nausea prevention drugs, and the rate is still only like 70% or so. So it could be improved. And this is the main takeaway from this study.
Interesting. And maybe basic question, but how long does the nausea usually last after the surgery? I have no idea about the time and how does it go, the slope basically.
That's a good question, and we did not ask that. Yeah, we asked on the first post-operative day, so about 24 to 36 hours afterwards. This is the data from our study, and for most patients it goes away relatively. So we're talking about first day, second day, third day. Normally not longer. If it's longer, then there's probably some other problems too. So it's not as important as, for example, chronic post-surgical pain, pain that develops after the surgery. But nevertheless, it's still an issue. It could still be handled better, and it is hampering patient recovery. That's for sure. And also activity levels, by the way. So if you're sick from nausea, you don't move. Yeah, you don't get up. That's for sure.
Yeah. Yeah, and you said that some surgeries cause it more. Were you able to kind of group them in a way that it would tell something like maybe cutting open the stomach or having something there causes more nausea than the knee? Or why do you think the surgeries, it's surprising that the cesarean, which is a big surgery, causes such a low level of nausea? Do you have any kind of guesses what could be the linking factor?
Yes. For cesarean section, it's guesses. We know that opioids cause nausea. So a lot of patients get opioids during the surgery, and they can cause nausea. Yeah. Among other factors. The anesthesia itself can cause it too. And in cesarean section, women tend to not take opioids. In a way, cesarean section is one of the most painful surgeries. On the other hand, it has on the 0 to 10 scale, it has a score on average of about 7. And this is way above everyone else. Yeah. So if you get normal operations are like 4 or 4.5, this is the average. So you're nearly 1.5 times higher than on average. But women want to protect their child. They often fear that drugs could influence the health of their child. And so they say, no, I don't want anything. I'm taking the pain for my child. And this could be a reason why it's very low. But as you said, actually, again, very good analysis. It's a visceral surgery. So surgery that are in the lower part of the torso. They are most prone to nausea. The musculoskeletal surgeries like knee or shoulder are not so bad, but shoulder, for example, was also in the higher group. So if you want to have a very short, it's those visceral surgeries and not so much the musculoskeletal ones. But it depends a little. And you have to look at the table actually as a surgeon to have a look which your surgery, a risky surgery or not.
Mm. Yeah. And now we have talked about the post-operative pain, chronic pain, and the nausea. What would be kind of your takeaways from the physical activity perspective? What do we kind of can sum up from these studies? What's the effective ways of supporting patients to get active and then get to normal activities of daily living, basically?
I had a coworker when I started in the pain field. She was a psychologist, Judith. And she always said a very simple solution: get a dog. If you have a dog, you have to go outside. You have to move. You have to be social. Yeah, you have to go outside, talk to people. Some chronic pain patients stay at home a lot. They are not socially active. They are not going to concerts or in the cinema. They are just staying at home, laying on their bed or their couch, which obviously is bad. And if you have a dog, you have to go outside. So this is a half joke, half truth. Yeah. But the message is the same. You have to get going. This is no really big news. Yeah. Everyone knows that. Take your steps, go outside, breathe fresh air, be active in your community. It will not always heal you, especially from chronic pain, but it will help you cope. And if you have anxiety or deficiencies in self-efficacy, for example, then staying alone at home is for sure not the solution. And yeah, get out. That's the message. Get active. Even if it hurts a little, it will improve your health overall and also concerning pain.
Sounds good and makes sense. And is there any new recent advancement in pain management that could be promising to improve patient outcomes?
I'm starting from the drug side. Actually, there are not a lot of drug developments in the last year that really make a big change or made a big change. There is no magic drug that solves it all. There are some drugs out there also for some longer time that can work in this or that way, but there is no new drug development that really changes everything. What is more interesting are those developments I told earlier about the multidimensionality of pain. So it is now realized that only treating the pain itself with drugs is not the solution, especially for chronic pain patients, but they need a multimodal approach. So they need to get drugs. They need to have a physiotherapist that works on their body. They need instruction. They also need a psychologist that talks about their possible social issues, that talks about going back to work and stuff like that. And this multimodal approach is much more promising and also in the research shows better results. But of course, it's much more expensive to do that than just to give a patient a painkiller. This is a very interesting development. And the second interesting development is the personalized medicine. We are now looking at patients not as part of a global population, but as a single entity that has special needs, has specific things where they are strong, specific things where they are not so strong. And if you have a large database, use artificial intelligence and machine learning to have clinical decision support systems that help clinicians to tailor treatments, especially for the patient that sits in front of them. And this obviously is a good thing, and it also costs money, but with the new developments, especially in artificial intelligence, these issues are researched more and more. And for cancer therapy, for example, they are relatively far for some kinds of cancer. And for pain, it is also coming. This will be the future. In the next 10 years, we will probably have clinical decision support systems that help clinicians to treat every patient specific to this patient's needs. And that's probably going to help much better than, just giving them one drug.
Yeah. Maybe we talk a little bit about the AI, as you are also expert on that.